Good afternoon, everyone. Welcome to this month's AFPHM webinar. Today we have Dr. Jeremy McAnulty presenting on outbreak investigation. A reminder to all participants to please use the Q&A function located at the bottom of the control panel to type through your questions, and we'll have Dr. Jeremy McAnulty answer them at the end of his presentation. I'll now hand it over to Dr. McAnulty.
Great, thanks very much, Terence, and I hope you can all hear me okay. So today, look, I work in Health Protection New South Wales, which is kind of the, well, for New South Wales Health is the health protection area that looks after environmental health and communicable diseases, and we get involved in surveillance of disease and outbreak investigations in a range of things. So today I thought I'd talk you through a scenario which has been fictionalised but based on an epidemiologic study that the team did, including one of your colleagues, Anthea Catalaris, who's presented the real outbreak. This is a fictionalised version, really, to try and bring out some teaching points. So it's a scenario where it unfolds, and I'll ask some rhetorical questions as you go, where if you could think through what the answers might be, but I'll pretty quickly go on and get to the next part of the scenario. So hopefully it'll work, and if it doesn't, let me know at the end. The first thing to say is managing outbreaks is really interesting, but it's complex, and you try and it involves all your skills you've learned from public health and epidemiology being kind of concertinaed into a very short space of time, where you have to use a whole range of things like epidemiology, biostats, collaboration and things together in a short period of time. So the things I want to point out to start with are there. People talk about 10 steps of an outbreak investigation, which I'll kind of try and highlight in this. Those 10 steps vary depending on who you talk to sometimes. Remember, an outbreak, the clock is always ticking. You have to think, people are getting sick. Let's try and find the answer quickly so we can prevent further cases. And it's really important to make sure that you get help from experts. And people actually like to be asked for their expert advice in situations where there's an outbreak. So have a low threshold for seeking help, and communication, communicate early to the people who need to know. And importantly, put yourself in the shoes of those who might be involved, whether they're the people who are doing the investigation, whether they're the people who you might think might be causing the outbreak, or members of the public. Just think through how they might perceive the situation. And that helps you then manage the relationships and the politics of those involved. And remember, it's a fine balance between doing good and harm. So you've got to get the right information, and then with a good level of evidence that you're able to then put in public health measures. But if you do the wrong public health measures, you might cause harm to a business. So it's a fine balance. You need to assess the causality as you go and intervene where you reasonably can. And important to use outbreaks as a way of consulting with others, collaborating, but also learning and teaching others. So a bit of everything. So the scenario begins, it's the 16th of June. You have a new job as a public health physician in the public health unit serving the southern region of your state, and the population you serve's got about 500,000 people. Your job is to help the communicable disease team, which involves 2 registered nurses and a surveillance officer, to follow up on notifiable disease reports and outbreaks. But it's been pretty quiet in beautiful Murrin City, where your public health unit office is. There's been some gastro outbreaks in aged care facilities, some cases of meninge, and some pertussis cases in a school, and flu season hasn't begun. So life's pretty busy, really. But then you get a call from Dr. Mouse, who is the ED director at Murrin City Base Hospital. Murrin City's got about just over 30,000 people in it. Dr. Mouse reports that they've seen a few people in the last couple of weeks with fever of unknown origin, and wonders if it might be of some interest to your public health unit. So what do you do at this point? Well, you ask her about the patients, and she says there's 5 she's worried about. You ask her how old they are and who they are. She says they're aged between 23 and 32 years of age. 3 are women, 2 are men. 4 live in Murrin City itself, and 1 lives nearby in Ratusia, which many of you probably have travelled to, just 20 kilometres away. 3 of the 5 work on farms in the area and in some sort of short-term work, and 2 she doesn't know. And what are the symptoms? Well, they include sudden onset of fever, aches and pains, and generally headachy. And they presented in May and June. And they had a similar spate of patients a few weeks before. So they were really keen to figure out what was going on, the diagnosis of these patients, and ran some tests beyond what they might normally do. And most patients seem to have resolved after a week of oral antibiotics. They did a range of battery of tests for flu, respiratory viruses like paraflu, pneumovirus, RSV and so on, Q fever, leptospirosis, and they all came back negative. So they weren't quite sure what the diagnosis was. It seemed like something infective. And the thing that some of them were itinerant workers made them worry that it might be something they had in common. So you wonder whether you might need to get some expert advice, you being you and all. So you call Felix, your boss, and ask him what he reckons. And he's not quite sure and suggests talking to head office, the communicable disease branch there. Head office agrees with your approach and recommends it to call some experts. Recommend some experts you might better talk to. So just think, who might you want to get some advice from at this point? In the meantime, you also decide to get some more information about the 5 patients. So how would you do that? You've heard from Dr. Mouse, but you might need some more information about them. How would you do that? So it's now 17th of June. And you call back Dr. Mouse and ask her to identify the previous patients she's mentioned in that previous spate of cases. And there are 4. And with one of the RNs in your team, you review the ED records of those 4 and the latest 5 patients. And you decide to get their contact details and talk to their GPs. But only 2 have GPs listed in their records, and neither of those GPs have seen the patients since they last visited ED. So you decide to call each of the 9 patients. And it turns out you need interpreters for 4, as some are from India and Malaysia, and the other 3 are in the country on short-term work visas only. But the 9 patients all worked at the same farm, Farm A, which is 25 kilometres out of Murrin City. So you've got a bit of information now. What's your next steps? Well, decide to check out the farm. You talk to Mick, the PHU Environmental Health Officer. And with Mick early the next morning on the 18th of June, you decide to drive out to Farm A and talk with the managers there. So it's a really big new farm, about 400 workers, mostly backpackers, as it turns out. And they grow berries and other fruit, raspberries, blueberries, peaches, apples, lots of fruit. Farm A has 4 artificial lakes. It's quite a big place, about 2,500 hectares, quite big, that supply, and the artificial lakes provide water to irrigate the fruit, because fruit needs good water. The workers work in 10 picking teams across the farm. And in recent weeks, there's been 5 teams working picking peaches and 5 teams working picking raspberries. Now it's the 19th of June, and the lab pathologist calls you, who's been getting the specimens from the patients from Murrin City ED. She's been worried about what the diagnosis has been and mulling over it, and she's had some leftover blood from 4 of the patients, and she's been thinking lepto might fit the diagnosis, even though there's been some negative antibody tests. And so she's got an in-house PCR test that she runs against those 4 samples, and they're all positive for lepto, for PCR. So at this point, you do a Medline search and online searches for lepto, because you're not real familiar with it. Outbreaks of lepto, what caused them, and outbreaks of stuff on berry farms. So you're kind of seeing what's out there. So this is what you find. You find that leptos caused by bacteria. It causes fever, headache, muscle ache, chills, vomiting, red eyes. It's quite severe with complications that are listed there. And its incubation period is up generally 5 days to 2 weeks, but can be longer or shorter. And it's spread via cuts in the skin with contact with contaminated water or soil or animal urine. It's carried by quite a number of animals, particularly in their kidneys. And you can even get it from eating or drinking contaminated water. But person-to-person transmission is rare. And the risks include contact with animals, or particularly animal urine, contaminated water, mud, soil, vegetation. It's known as sugarcane, what's it known as, Anthea? Sugarcane cutter's disease, or something like that, because it used to cause big outbreaks in Queensland among sugarcane farmers, where the rats urine would contaminate them. And veterinarians and abattoir workers can be at particular risk, as well as farmers. People can get it from camping, gardening, bushwalking, rafting. There was an outbreak in Malaysia a few years ago when they went extreme whitewater rafting, and there was an outbreak there. So prevention is said to be across about covering up your cuts and abrasions with waterproof dressings, wearing protective equipment if you're in an industry where you might be exposed, particularly to urine or contamination. Showering and washing your hands effectively after work or exposures. Don't swim or wade in contaminated water. Wear proper footwear so you don't get contaminated mud or soil on you. And rodent control and cleaning up rubbish. So there you are. You know everything you need to know about lepto. Oh, no, there's more. You need to, it's diagnosed by antibody tests or blood cultures, which are actually quite hard to do sometimes, or CSF or urine cultures, or PCR, as the lab person did in this case. Treatment is straightforward with doxycycline or penicillin, and best given early. So I've got a bit of information. What do you do next? Well, the clock continues to tick. It's the 20th of June, and you decide to get some experts together. You've spoken to head office about who you might include, and you decide to get your team, head office, communicable disease people, a couple of friendly ID doctors who work in the area, a couple of public health experts from public health units around the state, a friendly epidemiologist who happens to work in Murray's School of Public Health, which is world famous, a lab scientist, a food risk expert, given the sources of infection, and you actually come across a lepto enthusiast from Queensland who runs a reference lab who you've identified. So you've got an expert panel. They're all pretty keen. What do you put on the agenda? Well, at the teleconference, you convene it and you go over the available epi data and lab results that we talked about so far. And you talk about what's missing, what communication to workers might be, and whether there's any preliminary prevention measures you might be able to put in place. And just summarising some of the test results, everything was negative really, except that the 4 patients tested positive for klepto and PCR. So I guess there's a possible range of possible things a teleconference of experts might recommend. What do you think they might be? While you dwell over that, you need to see also if there's any other cases out there. How might you do this? And what are you looking for? Having a case definition is really important at this point in any outbreak investigation. And in this case, you decide with your experts that you recall a case, somebody who's or a person who's presented to care since the 1st of April in the public health unit area with a diagnosis of lepto or symptoms of lepto, or could be lepto without another diagnosis, so fever, headaches, muscle aches. So question, do you include working on Farm A as a criteria in your case finding? You may not, because while we know about cases on Farm A, maybe there are other cases you just haven't heard about. There might be some sort of bias that's making you hear about Farm A cases over and above other people, but you want to have a broad aggregation of cases regardless of their exposures at this point. Now, it's important to form a team because there's a lot of work here and there might be a lot of work ahead. And so you're able to get some keen people from your public health unit, some of the EHOs chip in, and also calling around your local public health units. In head office, there's some additional staff who are happy to be drawn in to the investigation. Now, it's now the 21st of June. And so the team begins the work of searching through ED, electronic medical records, calling GPs, EDs, ICUs and nearby public health units, labs and ID doctors in search for other potential cases that meet that earlier case definition. And because lepto is a notifiable disease in your state, reviewing notifications that have been received in your area and across Australia. In case there's other cases out there that have already been reported, but just to get a sense of what the background rate might be. But because sometimes there's lag in reporting or missed reporting, it's important to follow up with those health workers and labs to see if there's anybody who might fit those criteria who haven't yet been reported. And in addition to calling, you also send out a notice to your local GPs, EDs, ICUs and labs to get them to be aware that there's an outbreak and to consider lepto diagnosis in people with compatible syndromes. So will all these people you find have lepto? Possibly not. They might have other things, and that's where applying a case definition and doing additional testing will help. So you've been talking a lot with head office and now decide that it's time to start having daily, at least outbreak team meetings involving yourself, head office, the lab, to make sure that you've got a good understanding and sharing communication about what's happening in the outbreak. Starting the 21st of June. By the 22nd of June, you've re-interviewed the 9 patients and find they all worked in the raspberry teams on Farm A. Remember, there were 10 teams, 5 worked on peaches and 5 worked in teams that are responsible for harvesting raspberries. So you asked them about their illnesses, where they worked, what exposures they might have had that might have been at risk for infection. Turns out they do a range of different things in those raspberry teams. And some have worked for 2 or 3 years, others have only worked for the last few weeks. The sort of things they might do is some might manage the bushes, tie them back, manicure them, some might pick the berries, some might manage the irrigation, some might do the packing of the berries and load them on trucks for the market. And they only worked on 3 of those 5 raspberry picking teams. And they all wear gloves when picking the berries, which sounds sensible. And some of them admit to snacking on berries while working. So here's a little summary of those 9 cases you interviewed and what they did in that incubation period, which is 2 weeks before onset of illness. Picking berries, half had cuts on their hands, most had reported getting mud on their skin, none reported swimming or going into those artificial lakes. I was sure that was going to be the cause. None reported drinking untreated water. I was sure that was going to be the cause if it wasn't swimming. 4 of them ate berries while picking. All wore gloves. Not many wore eye protection. All wore boots, which were pretty sturdy, and all said they washed their hands after their shifts. So it's now 23rd of June, and your public health team has found another 33 possible cases by doing all that active surveillance. and has been talking with the clinicians to arrange testing on them. And your team has contacted all 33 and found they all worked on Farm A. Pretty unbelievable. How might you organise this data? You've got a lot of data now on the 33 patients plus those original 9. How might you do it? How might you look at it? Well, time, place and person. So time is an epi-curve, and this is an example of an epi-curve, which is simply a case of count of cases over time. And so it's now around the 23rd of June, and you can see a bunch of cases have been reported, and oh, they've stopped. Oh, but that's maybe because we haven't got to this future time yet. So we don't know it's stopped yet. Place, here's a map of the local health district, and you can see that by place of residence, all the cases, just about, except for 2, live in one little area here, which happens to be Murrin City. And here's a bit of the demographic information you've got already from the cases, largely from their medical records or lab information. So they're all young adults, mostly male, and come from a range of countries. Australia only one of many. And their medium time of living in Murrin City is just over a year. So some short and some longer, much longer periods. So what do you do next? You've got some information about their time, place and person, and it's a little bit of information about 9 cases. Well, the Murrin City Examiner's star reporter calls you that afternoon because she has heard that a Loganberry farmer has reported that there's a deadly disease killing workers in the big farm out of town. What do you tell her? You've got a lot of information so far, but why is this outbreak occurring and how could you stop it? You need more information. I'll leave you to think about what you might tell the City Star Examiner's star reporter. Sorry, Murrin City Examiner's star reporter. But let's get on with the outbreak. You need more information. Can you do anything to help prevent cases in the meantime? So from the literature search and chats with experts, you know that lepto usually is transmitted through cuts in the skin or ingestion. You realise that there may be worker safety issues, so you contact Minnie Johnson at the Worker Safety Authority and explain the situation. It's early on the 24th of June, and you drive to Farm A with Nick, the AHO, and Minnie from Worker Safety, and check out what the workers are doing that might get them exposed. The manager there is a little perturbed. He got a call from the Murrin City Gazette just this morning and doesn't want any trouble. You explain that you know so far, what you know so far, and the imperative of preventing more illness. So your team has a good look around and talks to some of the workers. And this is what it looks like. The vines are strung along wires, all inside huge open tents and watered by piped-in water from the lakes. Looks all very controlled and pure. The workers only drink town water brought in by truck in sealed bottles. They wear good solid boots. They wear gloves, all right, but they're fingerless cotton ones. And so they're cotton and they're designed really to protect the fruit from being squashed, not to protect any contamination of the workers' hands or scratching of the workers' hands. And there are thorns all over the vines, and you see a few scratches on the hands of workers. And you even try and pick a berry yourself and prick yourself. You walk into the fertiliser shed for a look and hear a lot of rapid rustling. Notice a couple of dead rats in one corner. Is there anything you want to recommend to the farm and the workers at this point? And what do you think of the source of the outbreak? Well, after talking through with the team, your boss, work safety, and head office, you recommend a number of things. First of all, informing the workers and managers about what's going on. So you get translated verbal and written information about the outbreaks to workers. Regular checking for and covering any scratches the workers might have in case the urine might be a source of infection for the staff through their injuries on their hands. Protective eyewear and impervious gloves to be worn at all time so that there's not an exposure route for any contamination to workers, and rodent control. The manager listens and but isn't sure that this is a good use of his resources, but agrees to do something for a few days. But it's expensive and he needs proof. Gloves cost a lot of money. It's hard to make sure that their workers are complying with such stringent controls at all times. Although the expert panel that you held did a food risk assessment about leptobacteria, and what they said is that the lepto are quite fragile and probably wouldn't survive on berries very long and haven't been associated with foodborne outbreaks in the past. And so there was no recommendation that it was unsafe to eat the berries for people. You still feel a bit nervous because you've got an outbreak among workers. So what else could you do at this point? You've given some preliminary information and recommendations to the people at risk, of the farmers and the berry pickers. Is there anything else you can do? Particularly given the managers agreed to do something for a short period, but we don't know for how long. Well, rats and mice and other animals can carry lepto, and you saw some rats, but why is there an outbreak now? You decide to do an epi study to hone in on what the risks might be. And you decide to interview all 42 patients about their exposures and any new cases that are subsequently found. So the questions are, what do you ask about? Do you need a comparison group? If so, who might you use? What sort of study could you do? There's probably a range of options, case control studies, cohort studies. But you decide to compare the reported exposures among cases you've identified, those 42, with those of other raspberry pickers on the farm. And you decide to do a case control study. So think about why you might do that, as opposed to another sort of study. But why don't you pick the other people on the farm, or include the other people, such as pitch pickers on the farm, as controls? So you decide to interview sick and well raspberry pickers who worked on the farm between April and June. This includes the 42 original cases and any new ones. You aim to get about the same number of controls as cases. Then you realise, well, lepto can have asymptomatic infection. Would that be an issue? Could all the people on the farm actually have had lepto, but only a small proportion being symptomatic? How would you deal with that? So you decide that to help manage that, you might do symptoms checks on people who are participating in the case control study. You can also take some blood to check for serology to see if there is any undiagnosed disease. That might help you understand what the risk is overall as well. And you and your team work out on an interview questionnaire. And by luck would have it, there's a community clinic 100 metres up the road from the farm gate. Would you believe it? After a bit of discussion, the local health service is delighted to make the clinic available and some staff to help out. They even arrange some interpreters to be on site should you need it. In the meantime, another 25 patients, all from the same farm, have been reported lepto diagnoses from the lab. Now it's the 1st of July, and you arrange for the expert panel to meet again and review where you're up to. The panel endorses doing an epi study. They query whether you've got the right number of controls per case, about the same number. Would you be better off getting twice as many controls per case to be more efficient? But you realise you may not have enough resources to do that, but it's a good question. And they also say, why don't you do a cohort study where you just get everyone on the farm who's worked on the farm and to participate and sort out by bleeding them and interviewing them who might be cases and who might not be cases, and then look at the exposures they had and get a better estimate of risk. But after a lot of discussion, case control is probably the more efficient because you can identify, figure out who non-case who the controls are, serology. And after all, you do have resources, and interviewing 400 staff members might be a stretch. The expert panel also thinks that the outbreak could be ongoing. There's no evidence it's slowing, so workers should be offered prophylactic doxycycline. There's some evidence that this might be effective from a couple of papers that you identify. The farm manager is very happy to help arrange for all the workers to come to the clinic during the shift and to do an interview and have their blood taken. So it all seems pretty good. Even your boss Felix finds some funds to give them morning tea. And you get great participation of 90%, and the clinic over 3 days works like a dream. And then you get your results from your questionnaires that you put in a computer, and then I won't go through how to do an analysis in any detail of the case control study, but essentially you will do a 2x2 table that looks at cases and controls and what their exposures were, and compare those, and then work out what the odds ratio was for each variable of interest. And then, of course, you've got to consider potential confounding. You might do some stratified analyses and logistic regression to work out the statistical correlations between cases being a case and exposures. And having done that, you, with the help of some other epidemiologists and some biostatistics expertise, you're able to draw out some findings from your case control study, which involved 67 cases and 69 asymptomatic seronegative controls. In fact, in the results, you actually found a small number of potential controls, who test positive for lepton serology, so exclude those and left with 69 asymptomatic seronegative controls. So here are some of the results. So of the 60, and you've got a little bit of missing information, so some of the denominators vary, but comparing cases with controls, 67 cases, 69 controls, about just under half of the cases, just under half of the controls admitted eating any berries. So the crude odds ratio is around 1, just under 1, as berries being a risk factor. So that's kind of reassuring. You were worried a bit about, was eating berries going to be a source of the outbreak, but no evidence so far of that. Contact with irrigation water, similarly, a minority of cases and controls reported contact with irrigation water as being an exposure. Again, you've got a odds ratio of just over 1.7. It's not statistically significant. And all cases and all controls report hand washing. Some more data, this time looking at, in the first analysis, a trend test, well, looking at the trend of number of scratches that workers, both cases and controls, report having on their hands. And you can see, starts off with they're rarely scratched, often scratched, or always scratched. There seems to be some association between being always scratched, having scratches on their hands, and an increased likelihood of being a case. Similarly, contact with mud appears to have an elevated odds ratio, and being a raspberry picker on the raspberry team was strongly associated with being a case. And then finally, reporting using any gloves seemed to reduce the risk of being infected. The longer you were employed, or the shorter you were employed, increased the risk of infection. Reported seeing a rat or other rodent increase your risk quite a lot of being infected, and requiring an interpreter also increased your risk. So there's some epi to mull over. In the meantime, it's the 3rd of July, and you decide to gather some more environmental evidence about what's going on. in part steered by your epi study. So I asked the farm manager for some of the animals that they have trapped, because they've got rodent traps up now. And in those traps, they've got 7 rats, 2 possums, 3 mice, and a cane toad. And you speak to your Queensland Uni lepto-enthusiast friend who works in a reference lab in the north of the country, in Queensland, and they're very happy to do some PCR testing on those animals' kidneys to look for infection. So you work with a local vet who can dissect some kidneys out and send them up for testing. In the meantime, you double check the water supplies and dams to make sure there's no risk of, or no obvious source of contamination there. And fortunately, the farm runs some CCTV security cameras around the farm to monitor the vines at night, because I've had some threats from some raids from some the activist organisation Free Berry Movement. It's the 10th of July. All 5 of 7 rats have tested positive in the lab from your friend in Queensland. All the other animals tested negative. McVHO revisits Farm A and finds that all the drinking water is town water and securely stored and delivered. And the 2 trainees you assigned to review the CCTV footage see rats frequently running up and down the vines on most nights. What do you do next? So it's now the 11th of July. You reconvene the expert panel and go over the findings. You tell the works, you discuss it with the Works Safe Organisation Authority, and the farm managers what you found and reinforce your previous recommendations about wearing gloves and protective equipment and covering wounds and so on. And the following day, you provide a written report to all those stakeholders. And then a few months later, you publish your findings in the New England Journal of Medicine. So here's a little summary epi curve of what happened. You can see cases rolling on until you get notified, and then they still roll on, and then you do your initial intervention, and then nicely there's a decline in cases. So that's the story, and there's some unanswered questions in there, of course, that I've left you to dwell on, but we might be able to take up in the discussion period. But essentially, there are a number of steps in an outbreak investigation that are worth remembering. I mentioned at the beginning that these can vary depending on who you talk to, but the ones I like to have are these. There are 10, and the first is established that there is an outbreak. Sometimes you can get reports of outbreaks that are just somebody's interested in the disease, it's not really an outbreak, finding more cases, or there's a new lab test come on board, or there's sometimes even a false positive number of tests that have been done because the test isn't working properly. So verifying there is an outbreak is an important first step. But essentially you're looking for, if all those things I said are legitimate before, there's a greater number of cases than you might expect. And you can see what you might expect from previous reports through the surveillance, talking to lab or clinical people about what if they think what you're seeing at the moment might be higher. Verifying the diagnosis is the next step, which includes typically lab. You can't always get lab confirmation. Involve syndromes, but ideally lab confirmation for an infection. Defining and identifying cases, so that involves the case definition we talked about earlier, which might involve syndrome plus lab testing. And then doing some active surveillance for cases that might involve searching medical records, contacting GPs, EDs, others, and testing patients who might fit those criteria. Performing the descriptive epidemiology, that's time, place, and person, so typically an epi curve, a map of where people live, and a description of the demographics, at least of the cases. And you can usually get that information from lab reports that are usually pretty handy to get, easy to get, even before you'd interviewed patients. Determine who is at risk based on the information you've gathered. Ideally, you should be able to say, well, we think this is one part of the state, or people listed in one particular location, or in this particular case, it might be people who have worked on a particular location, such as a farm. Developing a hypothesis, this is kind of the fun part of an outbreak investigation, where you kind of mull over and brainstorm about what might be happening based on the information you have to date. And in this case, was it rat urine getting incorporated, invading people through abrasions on their skin? Was it eating berries? Could it have been something else? And then once you get a decent hypothesis, evaluating whether there's some evidence to support it through a typical analytical study. So in outbreak investigations, we will typically use a case control study because they tend to be more efficient and more rapid to do than a cohort study. But in some situations, such as the outbreak we talked about there, you might be able to do a cohort study and get a better risk assessment of what the risk might be, the relative risk might be. Additional studies you need to think about over and above the epi. So in this case, testing animals, you might even be able to test the fruit for evidence of contamination. Reviewing the water supply to make sure that's not a risk. Checking the CCT footage for evidence of rodents on the vines. And importantly, implementing and control and prevention measures. Now, I've presented these as 10 steps, but in fact, they're not sequential. They often will happen in parallel. You don't want to wait to the very end before you implement things like educating workers, PPE, prophylaxis. Communicating findings is always an essential part, and really, again, you need to do that as you go. The one thing often you get caught up in is people feeling they haven't been communicated with, and particularly those outside your department might be the ones who you need to communicate most carefully with. Other agencies, and particularly if there's an outbreak in a particular setting, making sure that setting, the workers and the farm, across what you're doing and why, and what you find as it rolls out. But importantly, from a public health point of view, it's important to write it up to share with others. So earlier on, when you're doing that literature review, you should be able to find a number of articles about outbreaks of this nature that you can learn from. So if you don't write up your findings, others won't be able to benefit when they're doing their investigation of something similar. But also that publication is useful as a process for yourself and your colleagues to learn and improve about what your epi skills are like and your outbreak investigation skills are like. And it's an opportunity to reflect on the methodologies. Were they right? What the limitations were? What the caveats are of your findings? So publication is a really important part of communication. What I don't have here, but has become increasingly important over the years, is debriefing. So whenever you have an event that sucks up a lot of time, uses a lot of resources, it's important to debrief with those partners you've worked on to learn from the experience. How could you have done things differently? What were the lessons learned? And so on. Invaluable to be able to do that. Just finally, a word on association and causation, the Bradford-Hill criteria that are often used. Because you can do the epi studies and find an association between things, but that doesn't mean it's causal. Maybe people eating, if we found that people ate berries are more likely to get leptospirosis, that may not be causal, it might be just an association. And so there are various criteria that have been described that look at characteristics that make it more likely to be causal than just a simple association. So it said the stronger the association, the more likely it is to be causal. You get relative risk or odds ratios. Demonstrating a dose response, so the more scratches you have on your hands, does that lead to an increased risk of infection, or the more time you spent in the field being exposed, does that increase your risk of infection? The timing, it sounds very simple, but making sure the exposure occurred before the outcome. For some diseases, that's not always so obvious. Consistency of information, so does all the information you've got in your investigation, the various studies you've done, point in the same direction, or are they inconsistent? Does it make biological sense that an outbreak might be caused by rats running up and down urine, producing urine that then gets into people's scratches? And specificity, is there a single cause that produces the result that you're seeing? There's a couple of others which I won't go into. But that's my talk. And so I'll see if there's any questions.
Thank you. Yeah. So if you want to open up your question pane, you'll see that there's some questions for you.
Okay, so I'll read them out.
Yes, please.
First is, did I consider shutting the farm down? That's a very good question, and you may have, and you certainly would in this case. Now, remember, this is a farm that employs 400 people in a little town, and they're often backpackers or people who are probably close to the poverty line. So there is that question about doing harm versus benefit. And you could argue that you'd want to, if you shut down the farm, put people out of employment, would you do more harm than benefit? So it's a very good question of which you need to agonise over and seek a lot of information, ideas about. Second question from an anonymous attendee: where does the budget come from for responding to these sorts of things? Do they just get absorbed, or is they set aside outbreak funds? What happens if there's a huge expensive outbreak? Who pays? Typically, they get absorbed into the running operation. So in public health units and in head office, we have a number of staff who work on surveillance and other things. So typically we redeploy people into what's called surge capacity. So they're taken off and deprioritise other jobs. And if we've got a network of public health units, we might ask other public health units to help out remotely in following up routine work. But if there's a huge outbreak like a pandemic that's got extraordinary costs in testing and overtime, then we'll seek additional funds from our own finance people or from Treasury if it's big enough across government. But that's pretty unusual. But we also, sometimes in the past, we've held a bit of an outbreak contingency fund. Third question was from a public health unit. Why didn't the proponent fund my case control study if they're the ones who want proof? Despite a clearly elucidated mechanism of transmission, I doubt negative results in the case control study would change my recommendation to wear impervious gloves. Very good point. Very good point. What the part of this question is, would you get the farm to try and fund this overtime and work you're doing? Well, you could. I guess there's a lot of diplomacy involved in outbreaks in trying to keep people on side, because even though we've got the Public Health Act that can require people to do stuff, we still need people's goodwill. And if we start charging people for stuff they may not be convinced about when we want an acute answer, we probably would run into more difficulties. So diplomacy is key. If it was, would it change our results doing a case, if we got a negative result in a case control study? Well, there's lots of reasons to doing a case control study. One is, in this case, the manager was happy to do something short term, but I guess to make permanent change, there's nothing like solid data to make a case. And particularly if you're part of a big corporation that the farm might work for, having scientific evidence that's published will, I think, help make them be convinced to make changes. And also regulatory agencies like work safety agencies will probably believe data more than anecdote. Anonymous attendee. What role does the media play in outbreak investigations? Would you ever use media tactically, i.e. for more case finding? People pay attention, do usually stay out of the media. Yes, sometimes we do use media for case finding and tactically. So first of all, if it's a community-wide outbreak, which wasn't the case here, we will generally use the media to talk about what the general public can do to minimise their risk of getting measles by getting vaccinated, whooping cough by looking out for symptoms of getting vaccinated. So there's often a call to action we can use that's initiated by an outbreak investigation that might have more broad implications. Do we ever use of case finding? Sometimes we do. So I'm just thinking of an example. Once I was involved in an outbreak of pneumonitis due to a newly formulated waterproofing leather spray waterproofing spray. And we actually then went to the media because there was no lab test. So we actually went to the media and said, if you've got these symptoms, please report to your doctor and call this hotline. So we do that. Sometimes we did that with pandemic influenza as well in 2009. Anonymous attendee. Gee, you ask a lot of questions, anonymous attendee. Ultimately, who is responsible for an outbreak on a farm? Well, it's a good question. And I guess in occupational settings, you could argue that the Worker Safety Authority would be ultimately responsible. Well, the farm owners and operators would be ultimately responsible for protecting their workers, but that's regulated by worker safety organisations. But in health, if there's an outbreak, we like to help. From Karen, how long was the doxycycline prophylaxis for? Typically you prescribe it for a bit like malaria, up to a month, I think. But it's a good question. When do you stop giving workers doxycycline? Because if you're giving everyone prophylaxis, maybe the control measures aren't working and it's just a prophylaxis that's stopping cases. So when do you stop the prophylaxis regime for the workers? So it's a judgment call. It's very hard. From Public Health Unit, lepto is a life-threatening condition. Were there any fatalities, including unexplained fatalities of workers living in the area? Does New South Wales Health have a normative role in advocating for a strong legislative response from Safe Work to prosecute the farm for causing significant morbidity? Now remember, this is a fictitious outbreak I'm presenting here, so I'm not going to provide real-life comments, but I can comment on the principles, which is, so this keeps moving, so I have to reread it. But in this particular scenario, there were no fatalities. It was there are various strains of lepto which can have various levels of case fatality rates. Some are more mild than others. And in this case, this scenario, the Work Safety Authority were very concerned and didn't take prosecutory and regulatory actions. And from Karen, was doxycycline used more as treatment rather than prophylaxis? You could argue that doxycycline could be used, could have functioned as early treatment for people who were about to be symptomatic. And I guess we don't know everything about the dynamics of how doxycycline might work in these situations where we're giving it for prophylaxis. But essentially it was for prophylaxis. If people were symptomatic, then we would recommend to be treated. Just keeping an eye on the time. How would you, from Mike, how would a worst case scenario play out? Well, you could have deaths, and you could have uncooperative farmers and uncooperative workers, and you wouldn't have enough resources. There's all sorts of things that could go wrong in these things. And I guess you manage those risks by the sort of stuff I was talking about, having a team, lots of communication, having experts, diplomacy with the farm, all that kind of stuff. Oh, and Mike again. What are the most common causes of failure in management? Gosh, that's a good question. I'm not sure I know the answer to that. I think but I think it relates to my previous question, which is about putting in place, working with a team, communicating well, seeking expert advice early, making sure those briefing up, making sure that you've managed the potential media component, making sure you've got a good team, so making sure your resources are in place, so figuring out the surge capacity you need, not under-resourcing it, having regular, at least daily teleconferences often, but depending on the situation with all those involved, and debriefing. Okay, I'm just checking the time. Another question from Karen. Oh, are there any Public Health Act measures that allow investigation of the farm if the manager was not cooperative? Yes, there probably are. There's a Public Health Act that's quite good and allows us to go on a farm, go onto a location and take records, take copies of records, take samples of things. But also you've got to remember we're dealing with people, and people may not consent to working with us. They may make things difficult, particularly where we're trying to interview individuals about the illness or their exposures, and there might be other issues that we're not aware of, or that are other pressures on that person to cooperate or not cooperate, in such as would they fear losing their job if they, do the wrong thing by the farm or say the wrong thing by the farm. So I think, all that stuff I talked before about, including diplomacy and good communication, is important. It's not just about the Public Health Act, which we can and do apply when we need to. I suspect we're probably out of time.
Does anyone have any final questions? We have probably time for one more, if you're really quick.
No open questions.
We'll give it a minute, and if there's no questions, we'll wrap it up here.
And while we're doing that, I'd just like to thank Anthea Catalaris, who was instrumental in working on this with the local team that helped me prepare this presentation. Anonymous attendee, who must have sore fingers by now, has said, rat control. That might mean how do you control rats? Well, I think it's not being an expert, but you call a urinologist, who is an expert in rat control. And so there are various things like rat trapping, rat poisoning, but if you work on a farm, there are actually problems with using poisons where food might be involved. So you do need some expertise about that. One last question. Oh, it's a comment from that anonymous attendee. Thanks for an interesting presentation. That's a pleasure.
Well, thank you so much, everyone. Thank you to Dr. Jeremy McAnulty for your wonderful presentation. I had a very good turnout today. So thank you again, and we hope to see you next time.
See ya. Thanks.